Thank you so much. This is a huge honor for me to be here, and I have to, of course, thank Dr. Rogers, not only for giving me the opportunity to be here, but also for teaching me cardiology in general during fellowship at Duke, and also for bringing me back to the hospital that I was born in. This is the next time that I've been here. It was last year when they used to deliver babies here. So that's how old I am. So thank you so much for having me. These are my disclosures. So I've been asked to talk today about implementation, which is really the idea of turning what we know into what we do. And this is one of my favorite quotes: "A little knowledge that acts is worth infinitely more than much knowledge that is idle." And why is that relevant? Well, unfortunately, we know that evidence really does not translate into clinical care, right? Everybody's heard this quote: it takes 17 years to translate evidence into clinical care. But that's really saying something, right? Because we've been talking today about how everything is getting worse in terms of people's cardiometabolic health. But that's not because we don't know what to do. We have therapies beyond diet and lifestyle, which we've known for years. We have new therapies coming out literally every day that can help us to better manage these patients. And the question is, are we effectively utilizing them? So we looked at this in a commercially insured population. This was 156,000 patients with type 2 diabetes and atherosclerotic cardiovascular disease. And we looked at how many are on the therapies we know they should be on: high intensity statin, ACE or ARB, and an SGLT2 inhibitor or GLP-1. In reality, they should probably be on both for many of them. Only a quarter were on a high intensity statin. Only half were on an ACE or ARB. 10% were on an SGLT2 or a GLP-1, but look at that, less than 3% were on all three of these medications, and over a third were on none of them at all. And we were like, that cannot be right. This is not right. Something's wrong with this insurance program. So we said, okay, let's look at another data set. So totally different data set. This is now PCORNet, a large, distributed data network across many health systems. We looked at 12 health systems across the US, twice as many patients this time around with diabetes and atherosclerotic cardiovascular disease. Exact same thing. Less than 5% were on all three of these medications. Almost half were on none. And so you say, well, okay, at least statins. Maybe they weren't on high intensity statins, but patients with atherosclerotic cardiovascular disease are on a statin, right? So we looked at over 600,000 patients. This is again a commercially insured population just with atherosclerotic cardiovascular disease, with or without diabetes. Half were not on any statin at all. And these are therapies that have been around for decades, unbelievably inexpensive. And who are the people who are less likely to be on these therapies? Women, people who are older, peripheral arterial disease, just incredibly undertreated, and then people who are sicker in general were less likely to be on all of these therapies. So this is bad, right? This is really bad. How can we begin to make these things better? And so what I'm just going to talk about now for the next few minutes is a little bit of what we're trying to do at Duke, both locally and nationally, but there are programs going on all over the country. Clearly, Khurram and others have talked about things happening here. So there's great work that's happening all over the country. I'm going to start with what we're doing at home, the Duke Cardiometabolic Prevention Clinic. Dr. Rogers, you'll remember when I came on as a fellow, you were like, what are you going to do, Neha? And I was like, I think I'd like to build a prevention clinic. And so we have one now. It's still a work in progress. But the goal was really, it seems really simple, but it's also hard to do, which is to find the highest risk patients in the health system and to treat them in a multidisciplinary and coordinated way. And that's important because these patients, as we've seen today, there are many different clinicians that they're seeing. They're seeing primary care, nephrology, hepatology, cardiology, endocrinology, and they're falling through the cracks. And so we thought, if we can bring all of these clinicians together, can we keep them from falling through the cracks? Now, when we started this was pre-COVID, and so we thought co-location was really important. And now we realize, actually, we can do a lot, not just with co-locating, but we do have an entire team. So there are 5, and it is growing. We have 5 preventive cardiologists. We have trainees that are with us every day. We have a nephrologist who specializes in resistant hypertension, a hepatologist who specializes in MASLD and MASH. And we have multiple endocrinologists, some who focus on genetic lipid disorders and some who focus on obesity and diabetes. And so it really does take a village. And the idea is that we're trying to identify the highest risk patients. At the moment, it's referral based. But what we're aiming to do is to be able to identify these patients who are in need of care and better treatment through the electronic health record. And in particular, these are the patients who we're looking for, not just one issue, because they could just go to see that one clinician. We're looking for people who have more than one of either uncontrolled lipids, hypertension, diabetes, obesity, or other weight management issues, and then MASLD or MASH. And basically, what do? This is not the Mayo Clinic type system of round robin. Like, we couldn't make that work in our financial model. I don't know anybody else outside of Mayo that can. So what we are trying to do is really just practice team-based coordinated care. We meet every other week and we talk about our patients and we discuss the complex ones and we come up with management plans. And we are really aligned in terms of how we manage these patients in general. We really try to stick with the guidelines and evidence as it comes out. And we frequently communicate with the primary provider team. So this is one way in which we're trying to provide better care to these kind of high-risk patients with multiple comorbidities. But this is just one health system, right? What can we do that is going to make a difference more broadly? And so this is where the idea of the Coordinate Diabetes trial came from. And the Coordinate Diabetes trial, the objective was to test the impact of a clinic level, cardiology clinic level, multifaceted intervention to increase the rates of prescription of 3 key evidence-based therapies among patients with type 2 diabetes and atherosclerotic cardiovascular disease. And so we randomized 43 clinics. This trial now read out in 2023. We randomized 43 cardiology clinics across the US. They each enrolled patients with type 2 diabetes and atherosclerotic cardiovascular disease. About half were randomized to the intervention, which I'll talk about in a second, and half were randomized to just basic education, receiving guidelines. And then we looked at the proportion of patients who were prescribed all 3 of these therapies at 6 to 12 months, which is what we just talked about: high-intensity statin, ACE or ARB, and either an SGLT2 or a GLP-1 receptor agonist. And we purposely kept the inclusion criteria really broad so that this would be more generalizable. The patients had type 2 diabetes and one of these types of ASCVD. And if they were already prescribed all 3 therapies or already on an SGLT2 or GLP-1, they were not included, or if they had an absolute contraindication to any of these 3 therapies. And here is the intervention. So anything that is a multifaceted problem requires a multifaceted intervention if you're really going to do something about it. That being said, this was still relatively simple. There were 3 key components. One is understand what the problems are locally, assess local practices and barriers. And there was a clinic-specific assessment of barriers to prescribing the recommended therapies where the clinics looked inward and said, what are the problems? Why is this not happening? The second is fix those problems, develop strategies to overcome those. And so, for example, in terms of development of care pathways, one of the most common things that people did was they said, one of the biggest problems we have is prior authorizations. We have a pharmacist over here who actually can help us with that. Let's try and bring in our pharmacist to help us with prior authorizations, for example, for SGLT2s and GLP-1s. There was also an emphasis on coordination of care between endocrinologists and cardiologists, and there was a lot of clinician education and participant education as well. And then probably one of the single most important things was we gave people their data back. That's critically important anytime you're trying to improve quality of care. If people don't know where they stand, they assume they're doing great, and they're not, right? Because in general, we're not doing great. And so if you give people their data back, they can see where they're starting and how they're improving over time. It's also very motivating. And so these were the sites that we enrolled around the country. They each enrolled on average 24 patients. And this is what happened. So at baseline, no patients were on all three therapies at baseline. And at the end of, most patients were in the study till 12 months. At the end of that time, 14.5% in the usual care arm were prescribed all 3 therapies, and 23% greater than that were prescribed all 3 therapies in the intervention arm. So there was a significant benefit. And on the order of implementation trials, this is a pretty good effect. Now, if you're an optimist, you'll say, hey, that's great. That's better than most implementation trials have done, right? If you're a negative kind of person, you'd say, after all of that, there were still 2/3 of patients were not prescribed all 3 of these therapies. And that's true. That what this means is this can't be the only answer. There's still more to go, but at least hopefully this is a start. And what you can see is that for each of the prescriptions, the intervention significantly improved prescriptions, and really the greatest magnitude of benefit, as probably could be expected, was with SGLT2 inhibitors or GLP-1 receptor agonists. And we did look at blood pressure, A1C, and LDL control, but this was done in the height of COVID, and none of these were required, and so most care was being delivered remotely, and so a lot of patients didn't actually have these values. But for the values that were done, we didn't see any changes in these kind of intermediate markers. We did see, and before you get excited about the separation of curves, this was not statistically significant. This was never powered to be a clinical outcomes trial, but at least I think what this shows is that things go in the right direction, right? We're certainly not harming people here, and if you get people on the therapies that we know are beneficial, things start to go in the right direction. So the implications, besides that these therapies are underused, is that this intervention is effective, and if we can scale this, that would be really helpful. And so we share as a principle at Duke, all of the interventions that we do, all the implementation programs, we share everything that we create. And so all of our materials are online at coordinatediabetes.org. Every piece of information that was given to the sites, all of the assessments, everything was online. And basically, it's a roadmap for any clinic that wants to do this themselves. So that's a clinic level intervention, but what about health systems, right? So we've gone from one clinic to many clinics across the country, but maybe we should be going to large health systems. And so that's really what the Cardio Health Alliance is. It's kind of an extension of this work with the idea that if we can, I love the coalition of the willing concept. That's what the Cardio Health Alliance is. It's a coalition of the willing. It's health systems across the country who have decided, and their leadership, importantly, has decided that they are committed to improving the quality of cardio, kidney, metabolic care that their patients are receiving. And that's really what you need. You need institutional level support. And the focus right now is on cardiovascular, kidney, and metabolic disease, but that could obviously expand over time. And the idea is to establish a kind of a site and a consortium of health systems across the US that are committed to not just doing one-off programs to say, that was good, I tried this in my health system and I tried this in my health system, but saying, what if we did this across all of our systems? What if we randomized our systems to figure out whether or not this is really effective? And they're committed to doing that kind of work. So you can see here on the map, the sites in red are the ones that are already in our system, and the ones in yellow are potentially interested in joining. These are the sites that are already within the Cardio Health Alliance, and it has been sponsored by multiple pharmaceutical industry partners. And the 4 pillars are this idea of combining our data across these health systems. Most of them are part of the PCORNet Common Data Model, so allow us to combine real-world data, scale and optimize best practices, test new pathways, and also think about policy impact. And what I'll say is that so far we have multiple programs that are just getting going. It's a very exciting time for the Cardio Health Alliance. We have 3 trials that are just getting up and going. One is to randomize patients at a patient level to try and understand how we can improve rates of LDL testing when patients are in the hospital for an MI or revas. Do you know that less than 50% of patients who are hospitalized for an MI get their LDL checked within 6 months of their MI? Isn't that horrifying? So we're trying to fix that. And so that's one implementation program that we're doing that's called Test to Treat. V-inclusion is the idea that traditionally underrepresented and undertreated populations like women, racial and ethnic minoritized communities, and rural dwelling populations don't get the lipid care that they need. And so can we do better? And then the CKD program is just getting going, and that is with the purpose of helping to screen for and more appropriately manage people with type 2 diabetes who are at risk for and actually have chronic kidney disease but don't yet know it. So those are all programs that we're doing, and I would say in conclusion that yes, there are massive care gaps, but I do think we can be optimists. There's a reason for hope, and that is that rigorous implementation studies can help us to address these gaps, and we're trying to do this, and if anybody's interested in joining our efforts, we would love to have you, and prevention is cool. Thank you so much.